Hello, everyone. Welcome to another interesting session. So today we'll be having the case-based discussion, and like we've said, this is targeted at helping people here in the UK return back to clinical practice. This has been a long, an ongoing issue for many of us, IMDs, and is impacting the careers of people. So we've created this platform to allow as many of us come here, refresh your skill, discuss, have evidence for your portfolio, and most importantly, interact and support yourself while you grow and you go towards your goal. So today we have Dr. Alexandra, who's going to present in a case on dysuria and weakness. So I'll pass on the mic to Dr. Alexandra, and she would carry on from here. And then do please type your message in the chat if you have any questions. If you want to come on stage and be a panelist, please do indicate in the message section. Dr. Alexander, mic on.
Yes. Am I audible?
Yes, I can hear you.
Okay. Good evening, Dr. Aja. Good evening, my colleagues and everyone joined to this live stream. Like Dr. Aja already said, we are having a case-based discussion primarily aimed at helping to bridge the clinical gap that we some of us already have. And today is the first section, like he said, and the first topic or the first subject of discussion for these serials will be sepsis. Okay. My screen is already being shared. So like Dr. Aja said, it's a case-based discussion, and the learning objective for this section is for us to be able to recognize sepsis when we see a case, and learn how to apply the news 2 charts. We would later on learn the significance of the news 2 charts, especially within clinical practice in the UK. We'll aim to understand the initial management and how to escalate appropriately. So we'll start with the case introduction, which we got from a book. My references are at the end of the slide. All right, so for this case, we have a female AA. She's 70 years old, and she has presented to the emergency department following a referral by her general practitioner. She has come in with complaints of dysuria and urinary frequency of 3 days duration. This patient, Mrs. AA, has a past medical history of diabetes, and she is on metformin. She also has a positive history of frequent UTI. She lives in a residential care home. Now, on examination, it was noted that the female, Mrs. AA, was ill-looking, drowsy. She was febrile with a temperature of 38.5 degrees centigrade, and then her SpO2, her oxygen saturation, was 95%. On examination of the respiratory system, she had a respiratory rate of 20 cycles per minute, which apparently is normal. No abnormality detected with the respiratory system. On cardiovascular examination, she had a capillary refill time of 2 seconds. Heart rate was 110, which is tachycardia. Blood pressure was 80/40 millimeters of mercury. That is hypotension. Aside this, there was no abnormality detected with the CVS system. I forgot to mention that this patient was found to have cool extremities as well on physical examination. For the neurological system, abbreviated mental test was 5/10, which indicated moderate impairment. This test is actually used as a quick way to detect delirium or dementia in elderlies. Okay, total score of 10. It assesses a couple of parameters like the patient's orientation, including being able to, say her own name. Say the patient being able to say um, his or her age, being able to identify two people, for instance, a doctor and a nurse, being able to tell where the person is and being able to count backwards. So this patient had a score of 5 out of 10, which is moderate impairment. No focal neurological deficit was detected. On the examination of the GI system, there was suprapubic tenderness for this patient. Um, so after taking your history from your patient, you've examined the patient. It's expected that a couple of differential diagnosis should run through your mind as a clinician, and then you can narrow down from there to be able to clinch on a working diagnosis. So in this case, I have come up with a few differential diagnoses. Urosepsis top on my list. Urosepsis because of the history of complaints of dysuria and urinary frequency, the patient's age, and then my clinical findings. We'll find out more about this subsequently. I also thought of acute pyelonephritis because of the history of frequent UTI. She has fever, although no flank pain. I looked at acute kidney injury, maybe the phase where the initial phase of, polyuria as well. This patient is diabetic on metformin. She could be having some hyperglycemic crisis as well. Elderly patient as well with fever and all. Could also be pneumonia. You know that they could have pneumonia without the classical cough and all of that. This patient, on examination, she was found to be drowsy. She had an AMT of 5, so she could even be delirious or even having a stroke. It could be medication effect, maybe looking at metformin associated lactic acidosis. These are things I thought about, right? These are my differential diagnosis for this case. Sorry. Now, going forward, so recognizing sepsis. I did say that urosepsis was top on my list for this particular patient, this index patient. The reason I have chosen or have made urosepsis my working diagnosis here, or my most likely diagnosis, is because this patient has, I can say this patient has some clinical signs and symptoms that point towards infection and possible organ dysfunction. So for infection, I have fever, dysuria, and urinary frequency with suprapubic pain, being in favor of infection. And then this patient has a significantly low blood pressure, that is 80/40. Extremities were found to be cool. Patient is drowsy and AMT of 5, which could also go for organ dysfunction. Right, so patient is drowsy, AMT of 5, maybe confusion and hypotension. I found them to be my red flag. So this makes me think that in this case, I may be dealing with sepsis secondary to UTI in an elderly female. Okay, so before I proceed to actually do a clinical discussion on this patient that we are talking about, this index case, please, I want to kind of define sepsis and draw emphasis or throw emphasis on why sepsis is very important and why we should all have a high index of suspicion for our patients so that we do not miss out on sepsis. Basically, sepsis recently, I think in 2016, the definition of sepsis moved from the previous definition that we used to know, where we talk about the SIRS. So now the recent definition of sepsis is said to be a life-threatening organ dysfunction caused by a dysregulation dysregulation in host response to infection. So basically, what this is saying is that you have this life-threatening situation, that is in response to infection, and it comes from, kind of abnormal, probably immune response to an existing infection, and then comes up with organ dysfunction as well. So the organ dysfunction part is very significant with sepsis. And if I am to refer to the previous slide where I decided to go with urosepsis as my diagnosis, I've shown something that says infection plus organ dysfunction. And in this index case, the organ dysfunction we are looking at here is the hypertension, patients being drowsy, having cool extremities, and AMT of 5. So organ dysfunction, in practice, you may want to define organ dysfunction using a SOFA criteria. SOFA is where you talk about it. SOFA means sepsis related organ failure assessment, or you want to use the quick SOFA criteria. Now, the thing is that SOFA criteria cannot be used in the ED. ED is a fast-paced acute environment, so you can't use your SOFA criteria in the ED. Subsequently, we'll see a little more. We'll discuss a little more on SOFA criteria. Just mentioning it here. What you may want to use in the ED is the quick SOFA criteria. However, we are in the UK, and NICE guideline emphasizes the use of the NEWS2 chart. Use your NEWS2 chart to decide how soon you're supposed to manage your patients, and you also use it to risk stratify the patients using outlined structures and observation. We will see more about this as we proceed. We'll talk more about this as we proceed. Just a little on the epidemiology, like I said, just to emphasize why sepsis is very important, and why we always should have a very low threshold for suspecting sepsis in clinical practice. Is it low? Why we should have a high index of suspicion for sepsis in clinical practice. So globally, in 2017, there was a study that found out that approximately 49 million cases, approximately 49 million diagnoses of sepsis, out of which there was 11 million deaths was recorded. This was in 2017. My reference is at the back of this slide. I think this study was done by Roots. I'll pull up my reference shortly. Now, in the UK, it was extrapolated to be around 244,000 cases of sepsis in 2020, and this is from the UK Sepsis Trust. Now, approximately 48,000 deaths, as said, so approximately 48,000 deaths per year is said to be due to sepsis in the UK. Now, of these 244,000 cases we have, that was extrapolated to happen in 2020, and of them, they've said 48,000 will die. So 48,000 mortality would arise from sepsis, from these people who are diagnosed to have sepsis. It was said that 2/5, that's approximately 40% of the people who would survive sepsis would may have to live with some kind of sequelae from having sepsis. And it's also been said that sepsis is a leading cause of ICU admission, and that certain class of people are have been defined as or certain factors kind of make people more vulnerable. You can find this in the NICE guideline. People over the age of 25, people who live with comorbidity, like our patient is diabetic, which also can cause immunosuppression as well, and people who are frail. Our patient is said to live in a care home, in a residential setting, a care home as well. Just to add, globally, it said that 49 million cases would, 49 million new cases of diagnosis of sepsis in 2017. But the vast majority of these cases occur in resource poor countries, like in the sub-Saharan Africa. And um, you know, needless to say, you talk about their living conditions, sanitary, and in those areas, their socioeconomic status, that probably deprives them easy and quick access to, hospital facilities when they ought to go there. And we would find out shortly that the management of sepsis is very, very much dependent on time as well. And that's in all. When you try to merge things together, you find out that that can actually explain why in very resource poor countries you have very high level of high number of cases of sepsis, right? Going forward, so let's talk about risk stratification. So um of risk stratification of patients you suspect to have sepsis. Now, NICE does recommend that you have a very low threshold for suspecting for suspicion of sepsis, even in the absence of high temperature. So basically, what the guideline says is that if you think a patient has fever, a patient has an infection, um have a very high index of suspicion, or yeah, to think that this patient may actually be having sepsis, even if the temperature is not very high. And when you, at any point as a clinician, if you do suspect that your patient may be having sepsis, and this could be a patient who has just come in to the ED, as in our index case, or it may even be a patient who is already on the ward, and has been noted, or is being noted to be deteriorating, um, please, as a clinician, see your patient thoroughly so that you do not miss out on anything. And as said earlier, NICE does emphasize the use of your News 2 charts. And once you use your News 2 charts and you're able to collate the score, we'll talk about that shortly anyways, then you can decide, you can now risk stratify your patient and decide how soon from when you have taken your um initial vitals, which has come up to give you your News 2 score, should you be initiating or administering empirical antibiotics. So there's a time frame. For some cases it's 1 hour, some 3 hours, and um some 6 hours, basically from the time you have your values put together. For some cases you have to administer antibiotics within 1 hour, within the first hour. In some instances it has to be within the next 3 hours, and in some cases it has to be within 6 hours. So this helps you to ensure that antimicrobial stewardship is followed, so that you avoid resistance and all of that. So I did mention earlier that time is very significant in the management of sepsis, so the need for prompt identification and treatment. All right, so back to our index case. How do you actually manage sepsis? So there is a term called sepsis 6, which is very significant in the management of sepsis. Basically, sepsis 6 means you give 3 and you take 3. We'll talk about that shortly. But your management of sepsis actually should start from assessing your patients using the ABCDE protocol. And we already know for A, you are looking at the airway. Is this patient breathing? Is this patient able to communicate with me? In this index case, the patient has a oxygen saturation of 95%, so we do not need to give her oxygen. However, she needs to be monitored very closely in case she deteriorates. You're looking at the B, which is my patient breathing. You're looking at the first one was airway. Yeah, you're looking at my patient breathing. In this case, what's my patient's respiratory rate? You're going to examine the chest. Is the chest clear? And all of that. We did that at the beginning. We saw this patient had a respiratory rate of 20. The same thing you will do for your C, your D, and your E in assessing your patient. And then at every point you find anything that needs to be corrected, you want to, of course, institute correction as you go on. So in sepsis management, you want to give your patient oxygen, actually high flow oxygen, and your target should be a SpO2 of 94 to 98%. So that's your first give. Um, for your patients with in sepsis, you want to take blood culture, right? You want to take blood culture and send to the lab so that you are able to commence empirical antibiotics. Now, I'll just want to quickly pull up a chart, the news 2 chart for this our patient. I did the calculation and it was 9. So I'll just pull up the chart so that we can all see. All right. So for this AA, her respiratory rate on examination was 20 cycles per minute. So by our news 2 chart, she has a score of 0. Her oxygen saturation was 95, which is a score of 1. This patient, we only know that this patient is diabetic. There is no history of COPD, so I skipped this third one and I moved air or oxygen. The patient had an SpO2 of 95 in room air, and so she scored for this parameter. She has a score of 0. For her blood pressure, the news 2 chart does concentrate on the systolic blood pressure. For this patient, it's 80, and here she has a score of 3. Going forward, her pulse rate was 110. She has a score of 1. And now for her consciousness level. So the news 2 chart does have alert, confused, verbal response to pain, painful stimuli, and then unresponsive. This patient was said to be drowsy, and she had an AMT of 5. So she's obviously not alert, so she's confused, and that gave her a score of 3. Her temperature was 38.5. That gave her a score of 1, making her to have a total news of 9. Now, for a total news of 9, this patient would need very frequent monitoring, in this case, 30 minutes, every 30 minutes, and she'll need to be, you need to escalate this case as well. I'll pull up like a reference. So if we look at this reference chart, like we already found out, our patient had a total news score of 9. Now, if you look at this reference chart, the reference chart does say for an aggregate score of 7 or more, this is high. You need urgent or emergency response. And down here, it says for this double asterisk, the response team must also include staff with critical care. So going back to the index case, she has a news score of 9. And this also makes her a high index case, basically, where you need to respond immediately. I'll pull up another chart as well. So this is a screening tool, right? It's a sepsis screening tool for acute assessments. Basically, what this tool says, I'll just go down to number 2. In this number 2, it says if the news, okay, all right. Now, if the news 2 score is 7 or above, remember our patient had 9, or had any parameter of maybe 3 in 1, had a score of 3 in 1 parameter and all. If you have this as a yes for you in your patient, this means that this is a high risk, and then you have to start your sepsis 6 immediately. In fact, you can see it's colored in red, and you have to start your sepsis 6 immediately. Now, one thing about the sepsis 6 for this case, for patients who fall in the high risk, is that you have to institute antibiotics, empirical antibiotics, within 1 hour. So that within 1 hour is basically, let me see if I can pull it up from here. So that within 1 hour is basically saying from the time I'm able to get my vitals and I put it up together, it is 9 or above 7 or equal to 7. I must ensure that my patient gets antibiotics in the next 1 hour. So this our index case is high risk. Now, the antibiotics given is empirical, and it will always depend on your hospital protocol. Before we move on to the case, let's just digress a little bit. So if this patient had a news score of, say, 6 or 5, she would have been in the moderate risk category, amber. And in this category, the antibiotics, you can see it here, 0.3. You want to give her antibiotics within 3 hours, right? Within 3 hours. So there is another category. If this patient doesn't fall in this high risk or moderate risk, you are looking at antibiotics, commencing empirical antibiotics within 6 hours. That's what the guideline says. So going back to our sepsis 6, we have given this patient, commenced this patient on oxygen. We've taken blood culture. We suspect sepsis, so we've taken blood culture. Because we've taken blood culture, we are able to give her antibiotics within 1 hour because she has a new score of 9. Mind you, our patient is also very hypotensive. She had a blood pressure of 80 over 40 millimeters of mercury. So we want to give her IV fluid as well immediately. So we ought to have in our ABCD assessment, ought to have inserted a cannula, a wide bore cannula for this patient, except otherwise stated. Now you want to give her fluids, 500 milliliters of fluid given over 15 minutes. It's advised that giving a bolus is usually better. So 500 mils over 15 minutes. Then you reassess the patient, and if the blood pressure is not optimal yet, you want to give another 500 mil. Now here is the guideline actually does advise for, in this case, if after 2 bolus of 500 mils, that's if after 1 liter the blood pressure is not optimal, you want to consider escalating this case to critical care. Mind you, for this patient that has a new score of 9, you are already advised to ensure that the critical care team is even aware. So if you've given your fluid, IV fluid of up to 1 liter in 30 minutes and the blood pressure is still not optimal, you want to quickly escalate this patient so that you inform your seniors in case there is any need to commence vasopressor agents. So the other thing you want to take from this patient, you want to check this patient's lactate. So that's your second take now, lactate. And then the third take for this patient is that you want to monitor this patient's urine output every hour. Of course, you're giving fluid already, you're chatting. You want to monitor the patient's urine output every hour. So you're giving 3 and you're taking 3. You're giving oxygen, you're giving empirical antibiotics. In this our index case, you're giving within 1 hour. You're giving fluid as well. And then you're taking blood sample for culture, you're taking blood sample for lactates, and you're also taking urine to monitor as well. That's basically what sepsis 6 is. So in this case, there are other investigations that you want to do for this patient. You want to we are looking at urosepsis here. So you want to do a urinalysis and a urine culture as well, in addition to your blood culture, so that you have you cover more ground. And then in case her antibiotics would need to be changed eventually for optimal outcome and results, of course, this gives a better chance as well. You want to do your urea and creatinine for this patient, and electrolyte as well. You want to monitor the liver function for this patient. You want to do your full blood count with differentials as well. One important thing about full blood count with differentials, apart from the fact that it gives you, a picture of what's going on in terms of the infection, it also can tell you about the patient's platelets. And remember that in sepsis, DIC can be a complication, and we all know what DIC is. So another thing you want to do for this patient is a coagulation profile, also because of the risk of DIC as well. You want to consider a chest x-ray in this patient, because this patient is elderly. She's 70 years old, and sometimes they could even have pneumonia causing as the cause of their sepsis, and not even have the typical cough and all that we would expect. Sometimes it could be atypical, right? Yes, I already talked about giving crystalloids and reassessing your patient very frequently, every 30 minutes, especially because you have re-stratified her to be in the very high risk group. Okay, I talked about escalation earlier. I talked about the need to probably escalate to critical care, which is ICU or HDU, as the case may be, especially if she remains hypotensive. or you are considering giving vasopressor agents as well. Clinical costs for this case. So in urosepsis can be treated, using your sepsis 6. And the patient may, of course, recover and get discharged. There is also the possibility of the patient being readmitted. And then there is the possibility of the patient, having to be transferred to the HDU. All right. I already talked about what the patient has gotten. Now, I did mention the SOFA score earlier. Like I said, SOFA score is not something you want to use in the ED. However, the SOFA score helps you to identify how severe this patient is. It also helps you to, for prognosis as well, right? Something you do by the bedside. It requires a couple of blood tests as well. So it's not something that you do in the ED when you have a patient that has just presented to you acutely ill. SOFA test, SOFA is sepsis severity, sepsis related organ function assessment. Basically, it assesses 6 organ systems. You can also use other organ systems, but basically this SOFA looks at 6 systems. It looks at the respiratory rate, where it considers the ratio of partial oxygen pressure to fractionated oxygen concentration, and then looks at coagulation, where it considers the platelet count. Remember, I talked about why your full blood count with differentials is significant, apart from the differentials part with the white blood cell and infection. And then, I talked about platelets. So it also looks at another organ, looks at the liver, where it considers bilirubin, looks at the cardiovascular system, looks at the blood pressure of the patient, and then if the patient would need vasopressors. You look at the central nervous system, where you are considering reduced Glasgow Coma scale. In the renal system, it considers creatinine and urine output as well. So basically, this is something you want to use in your HD or your ICU. It's bedside, it's not appropriate for ED. So if this score increases by 2 or more, it indicates that there is an organ dysfunction, and then you can use it to monitor your patient's severity and prognosis as well. But like I said, NICE emphasizes the use of the NEWS2 score and risk stratifying your patient based on that, and then acting swiftly. So NEWS2 is the UK standard tool, and it's basically considers patients' vital signs. So we have the quick SOFA. Quick SOFA can be used in the ED, but it's not advocated for in the UK. So basically, it considers the respiratory rate. If it is higher than or equal to 22, it looks at blood pressure that is less than or equal to 100, and altered mental state. Once you have 2 of these 3 parameters deranged, 2 or more of these 3 parameters deranged with the Q SOFA score, then it becomes significant. So basically, I try to look at what can predict poor outcome in a patient with sepsis. So for instance, in our index case, this patient is elderly, so her age, poor outcome increases with increasing age. The blood pressure in this patient was hypertensive. We had a blood pressure of 80, and then if this blood pressure if this patient remains hypotensive even after you've tried to correct, it's actually a poor predictor as well. High respiratory rate. So if your NEWS score is 7 or more, as we saw in this case, it automatically stratified the patient in the high risk group. If lactate is high, of course, more than 2, and maybe remains higher than 2, or even 4, up to 4, this can even be a reason to even want to refer or transfer the patient to the HDU. There are other factors here: comorbidity, patient is frail, and then the source of the infection, the primary source of the infection. So for UTI as a primary source for sepsis, it is said that it carries a better prognostic outcome, unlike when it is pneumonia. And then also very significant is your ability to institute or give antibiotics early. especially in this case where you have found out that, or you have been able to stratify this patient as very high risk, you need to give her empirical antibiotics within hour. Delaying it can work to the patient's disadvantage. Some I think there is a study. I am being very careful because I have not referred to the study here. I have not referenced it here. That says that instituting antibiotics early enough can reduce mortality significantly. I think up to half. Then you're also looking at the kind of organism that is implicated in the infection we are dealing with as well. Yeah, yeah. I think that's the end of this presentation. Um, Hello, Dr. Aja. Aja, are you there? Okay, so I'll just check the chat if there are questions on the chat. No questions so far. And yeah, I think I've come to the end of this presentation. Except we want to just take a few minutes to look at this sepsis screening tool. Okay, all right, yes. So we have a question. Please, can you go over the news score and how to calculate it? Yes, please. All right. So I will refer to the slide where we have the patient's examination findings. 1 minute. So the patient examination findings here. I'll just write it out so that I don't come. Do I take a screenshot? Okay. So this patient, where is my slide here? All right. All right. So for this patient, if you have to fill your news chart, of course, you start with the patient's name, date of birth, and date of admission, proper identifiers. You want to enter your date and enter the time where this exact vital signs was being taken and recorded. In this index case, her respiratory rate was 20. So I have recorded it here. And if you look at this under respiratory rates, it's color coded. I think this will pass for red, this will pass for orange, and this will pass for yellow, right? So the section that is colored red or highlighted in red gives a score of 3. The one that is highlighted amber gives a score of 2. The section that is white gives a score of 1. The one that is yellow gives a score of, the section that is white, right, gives a score of 0. And then the place highlighted yellow gives a score of 1. Now for respiratory rate, our patient had a respiratory rate of 20. Now it's under the clear section, that it's white. So this automatically respiratory rate is 0. So we have 0. Now, if you move on to the next section, so you're looking at the patient's SpO2. This is scale 1, so oxygen saturation. Now, I used scale 1 and not scale 2 because scale 2 does say that you have to use it in maybe when you have hypercapnic cases or hypercapnic respiratory failure. An example of hypercapnic respiratory failure will be COPD. And from our history, we don't have a history of COPD in this patient. We just know she's diabetic. So I use scale 1. Now, scale 1, this patient had an SpO2 of 95. And 95 is under the yellow section, which means she has a score, she got a score of 1 from her oxygen saturation. Now, moving down, now you have this section that says air or oxygen. Now, for air or oxygen, this patient had a saturation of 95 in room air. Now, it is clear, and that makes 0. That's another 0 for this patient. If you move on to blood pressure, for this patient, her blood pressure, this chart requires that you use systolic blood pressure only. Now, this patient's systolic blood pressure was 80, her diastolic was 40. So we are concentrating on the systolic, which is 80. Now, it falls within the section that is highlighted red. And that gives this patient a score of 3 from her blood pressure. Now, and this is under circulation as well. Remember, we talked about assessing the patient using the A, B, C, D, E. So that's how you're able to get all these parameters. Under the pulse rate, this patient had a pulse rate of 110 beats per minute. It is under the section that is highlighted yellow. That gives her a score of 1. If you move on to D, right? Excuse me. From the history, from examination, we found out that the patient is drowsy, and the patient had an AMT score of 5, which means that there's a moderate impairment. Now, if you look at this chart, is it that this patient is alert or not alert? Now, if she's drowsy and has AMT of 5, which means moderate impairment, it definitely means that this patient is not alert. She's not alert, so she's confused. So that gives her a score of 3. Under temperature, we had a temperature of 38.5. Now, that's in this range, and that's a score of 1. Now, if you total all the scores we had 0 for respiratory, 1 for oxygen saturation, 0 for the fact that the patient is on room air, then 3 for her systolic blood pressure, 1 for her heart rate, and 1 for her consciousness level, 1 for her temperature. All of this summed up together gave 9. So you put your news total here as 9. Do you need to escalate this? I said yes, and I'll show you why I said yes. Now, if you look at this chart too, the news threshold and triggers. Now, if you have an aggregate score of, in our case, we have an aggregate score of 9. So I'll just go down to 9. Is the section in red. Now, an aggregate score of 7 or more, of course, 9 is greater than 7, means that this patient is at clinical risk. So high. The clinical risk of this patient is high. This patient needs urgent or emergency response. Now, there's 2 asterisks here. The response team must also include staff with critical care skills, including airway management. Now, we are dealing with sepsis, I know. So if you refer to your sepsis screening tool, okay. So if you refer to your sepsis screening tool, you will find out that you're going to, okay, so number 1, you're starting with this chart. Basically, from O2 here, you find out that this patient is above 7. This patient is above 7. And we don't know about her lactates, we don't know about any lactate, but because this patient is above 7, she's high risk. The patient is high risk, so you need to start your sepsis 6 immediately. So that's why this patient is in this red category. You start it immediately, and you need to ensure that you give antibiotics within 1 hour of getting your new score. So we have another question. Can you go over okay, I've done that. Thank you. Can you talk more on the use of SOFA? All right, so for SOFA, hold on, I'll just refer to the slide. So basically, sepsis is two components: infection and organ dysfunction, right? Now, the organ dysfunction part is defined using the sepsis related organ failure assessment. That's SOFA, using the SOFA criteria, or you can use a quick SOFA criteria. Now, the SOFA criteria, the SOFA criteria um draws from a combination of six organ systems. Now, these systems are respiratory, coagulation, liver, cardiovascular, CNS, and renal. Right? One, two, three, four, five, six. Yes. So these are the systems and basically the parameters you have to look out for. Now, if a patient has come in, assuming this patient that we are our index case now, she was referred from the GP to the emergency department. When a patient comes in the emergency department, we know how fluid or how high acuity the emergency can be. You will not be able to. I don't think in the emergency you are able to ascertain the oxygen partial oxygen concentration, a ratio of that to the fractionated oxygen concentration. You're not even may not be able to get the platelet count immediately. I'm not sure you can get bilirubin immediately. Yeah, blood pressure you may be able to get. You may not be able to get creatinine and urine output. So so far, NICE has agreed that so far is not something you want to use in the emergency, for a patient that you've just been called in to come and see, that is acutely unwell. So this so far is something that is used commonly in the ICU or the HDU, because it's something that you do bedside. You get all these details together. It may take some time, and so if you have a score an increase an increase of 2 or more, then it indicates that there's organ dysfunction. So basically, SOFA is used to assess severity and prognosis of a patient with sepsis. The quick SOFA uses 3 parameters basically. It just uses the respiratory rate if it is equal to or greater than 22 cycles per minute, uses systolic blood pressure less than or equal to 100, or altered mental state. So once you have 2 of these parameters or more, then you just know that your patient is high risk and then you want to swing into action. However, NICE does say we should concentrate on using new score, have a very high index of suspicion for a patient that has infection. And if you have to see your patient thoroughly so that you do not miss out on anything, because sepsis even kills faster than, or even kills more persons than breast cancer does. Thank you. So safe to say the charts are plastered in the wards or departments. I would assume so. I don't know. All right. So I think there are no more questions, and we are 4 minutes away from 7 o'clock, from 8 p.m. Thank you very much. I hope to get feedbacks from this section, and also it's on YouTube, so it can always be referred to later. Thank you. All right, so in the absence of any more questions or contributions, it may be safe to end the call, right? Or do we just wait till? Okay, maybe just leave it running for the next 3 minutes. Stop, Dobby. This is such a dumbass. What is that? What is that? Put it down. Down. Bring down. Say! Don't stop, Toby. This is
right, left, to left, left, to left, up, to down, down, below, round, speed, and see. Don't stop, don't beat. This is how you do it. Don't, 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 don't. Put it right, put it left, put it up, put it down, down. Below, spin, and say, stop, stop. Don't stop, don't stop, Toby. This is how to do it. Don't, 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 don't.